Hi folks, and welcome back. In this part, we are going to start learning about the ear and the special senses related to that. So let's get started first with the anatomy. So the ear can be divided into three general areas: an outer ear, a middle ear, and an inner ear. And let's explore the structures associated with each. In the outer ear, there's really two structures only. The outer exposed part of the ear is called the auricle, or can also be called the pinna. And then you can see the opening, which is going to lead you into the temporal bone, and that's called the auditory canal or the external auditory canal. In that canal, we have normal stratified squamous epithelium, but it is loaded with ceruminous glands, which are glands that secrete a really waxy substance called cerumen. And this cerumen coats the entire auditory canal to waterproof it. It's also anti-insect, because if a little bug crawls in there and nibbles on this thinking, oh, I've met the buffet, it's very bitter, so it U-turns and hightails it out of there. And it has some antibacterial properties. Over time, the cerumen will dry up and it will fall out on its own. What you don't want to do is anything that pushes it in deeper and can make it get impacted. Looking at the auricle itself, you can see that there are a lot of protuberances and bends and all kinds of things. The upper outer curved part is called the helix. And the lowest most part is called the earlobe or the lobule. On some people, it is not attached to the skin of the scalp and can be flicked, and other people, as in this picture, it is actually attached to the head. Just anterior to the auditory canal and protecting it is a protuberance, a firm protuberance called the tragus, and opposite would be the antitragus. So most of the auricle contains elastic cartilage. The part that doesn't is the earlobe, and that's just mostly adipose tissue. So remember, if you're piercing through any cartilage, that cartilage does not have a blood supply, so it is super slow to heal, and your chances of having a complication with piercing through cartilage is significantly higher than just piercing through the softer, non-cartilaginous structures. Now, related to the middle ear are two structures. The first is the dividing line between the external ear and the middle ear, and that is the tympanic membrane, which is known by all your family members as the eardrum. Another structure which is related to the middle ear is the eustachian tube, also sometimes called the pharyngotympanic tube, and it extends from the middle ear to the pharynx. And so the pharynx has three parts. Basically, your pharynx is your back of the throat, but it starts up in the back of your nasal cavity, which is where the other opening for this eustachian tube is. So it connects basically the nasal pharynx to the middle ear, and normally it will collapse down on itself. And so both the external and middle ear contain air, just like the air out here and the air in your nasal cavity. But when you go up to altitude or you're going down like you're scuba diving, what happens is the atmospheric pressure has changed, but if the eustachian tube is blocked, then the middle ear pressure is not the same as the atmospheric pressure that you're in. And so that's why when you're on airplanes and you're taking off and you're landing, you chew gum, or sometimes you stretch or whatever until you hear your ears pop, because what that ear popping is your eustachian tube opening back up to equalize the pressures. Now, I do want to point out on this picture of a baby, one really important thing that has to do with eustachian tubes in babies and why it's so important to feed your baby's in an upright position, because if you take this baby and put him on his back and you have the baby sitting there holding their bottle themselves, or if your baby is flat on the back and you're feeding the baby like that, like for instance, lying flat in bed, I want you to realize that any of that fluid that is in that mouth cavity can very easily go straight back that eustachian tube into the middle ear, and carrying all those bacteria in your mouth back there with it. And then those bacteria have their buffet in the middle ear, and they can set up a middle ear infection, which is not good news. So take the time to hold infants in the correct positioning for feeding, or you will be losing sleep while that child is up with an infection. Okay, now in the middle ear, we have 3 ossicles, and the names are the malleus, incus, and the stapes. And so one will attach to the backside of the tympanic membrane, and the third one attaches to the opening of the inner ear. So they're always attached in the same direction. The most external one is the malleus, which looks kind of like a mallet, which is like a hammer. And so if you look at the handle of the malleus, at both aspects, the upper and lower aspects of the handle of the malleus, that will be attached to the curved portion on the backside of the tympanic membrane. So when the tympanic membrane moves, the malleus is going to move. And the malleus is attached to the incus, which is an anvil-shaped structure. So if the malleus moves, the incus is then going to move. And then the incus is attached to the stapes. And the stapes is a stirrup-shaped structure. So for instance, if you were going horseback riding, you would slide your foot into the opening. And so the bottom part of the stapes, the foot plate of the stapes, has this oval shape. And the oval shape matches perfectly the opening in, and actually covers the opening into the inner ear. So there are 2 openings between the middle ear and the inner ear. The one that the foot plate of the stapes is over is oval shaped, so it's called the oval window. And then inferior to it, there is a much smaller but round window. We'll talk about their significance when we talk about hearing. So moving into the inner ear, we are then inside, deep inside the temporal bone, where we have this curved pathway, which is known as a labyrinth. And so we have this bony labyrinth inside of which we have membrane that follows the same labyrinth for the most part, and that's called the membranous labyrinth. And the membranous labyrinth, there's one part of each part of the membranous labyrinth, there's one area of each part that contains the receptors for all of our special senses in the inner ear. So we'll have one area containing receptors for hearing, and we'll have another area, or actually multiple areas, that contain receptors for equilibrium. We'll talk about those functions at a later time. So if we look at this labyrinth, the bony labyrinth is the more external part, which is represented by this brownish part. And inside that, where this blue line is, that would be the membranous labyrinth. Okay. So inside each of these labyrinths, there actually is a fluid. So there's fluid inside the bony labyrinth, but outside the membranous. And then there's a different fluid inside the membranous labyrinth. So the fluid between the bony and membranous labyrinth is called perilymph because it goes around the membranous labyrinth, whereas the fluid inside the membranous labyrinth is called endolymph because it goes inside. So when we're looking at the bony labyrinth, there are 3 specific structures, all of which are going to have perilymph inside them. At one end, you will have 3 circular structures. They're not complete circles, so they're called semicircular canals. At the other end, you're going to have this wound up snail-like structure called the cochlea. And between the two is the entranceway to the entire inner ear, and that's called the vestibule. Because a vestibule is like the entrance to a big building. This is also the vestibule. Inside these three structures of the bony labyrinth, we are going to have the membranous labyrinth, but there are 4 structures to the membranous labyrinth, okay? All of these structures are going to be filled with endolymph. Inside the semicircular canals, you're going to have semicircular ducts. Inside the cochlea, you're going to have a cochlear duct. So it's that central part where the vestibule is. That has 2 membranous components. The larger component is closer to the semicircular canals and ducts, and that's called the utricle. The smaller component is closer to the cochlea, and so that's called the saccules. So anytime you see the word duct, you know they're talking about a membranous labyrinth, so it must contain endolymph and be surrounded by perilymph. So I've made this little starter table for you, giving you the names of the bony labyrinths, the membranous labyrinths, and right now, kind of like the Sparks Note function. So as you're studying and going on, go ahead and fill it out and add more details. So a couple of comments. Leave your ear alone. Q-tips were not invented to stick into that auditory canal and try to get earwax out. They were invented to go under the helix and around where the tragus is to clean dirt out of there, especially they were invented for newborn babies to clear that part. Here's the problem. When you're sticking a Q-tip in your ear, you have no idea how far down you're sticking it. And it's very easy to stick it through the tympanic membrane. And in fact, this happens thousands of times in the United States. It's a very common emergency room visit. And this is what the practitioner sees when they look in your ear. This huge hole with this bloody stuff around it. And the only way this is going to heal is by scarring. So are you going to have hearing loss later on? You betcha you will. Okay. So keep Q-tips out of your ears, and please don't do what other students have told me. Okay, so I'm not using Q-tips, but is a chopstick or the end of a fork? No, nothing. Put nothing in your ears. If you want to play with any of those things, take your Q-tips and make some art out of it, okay? All right, that's the end of the public service announcement, but let me talk about a couple of diseases related to the ear. The first is otitis externa, which you probably haven't heard of, but it's also known as swimmer's ear, which you probably have heard of. And the reason for that is this occurs because fluid is stuck in the external ear and it sits there and everything's really moist and wet, and so it's very easy for pathogens to grow. And so because people swim a lot in the summer, and you swim and before your ears dry out, you're going swimming again, so your ears can be wet practically the whole day long. This is why we have a lot of otitis externa in children in the summer. So just make sure if you're swimming, you tilt your head and you make sure all the little drops of water are on both sides. If you can feel fluid in there, tilt your head and get the fluid out of there. Do not be putting Q-tips in. Okay, you can kind of tell you have otitis externa because it's very itchy and scaling. It's usually bacterial, and when the healthcare practitioner looks at your ears, it's all this crustiness, and if you have been poking at it with Q-tips, then what happens is you can get this super infection with all this pus coming out and all this redness, and it just takes longer. There's nothing you're going to do by sticking a Q-tip in it except make it worse. All right. Now, that is totally different than otitis media. Otitis media is a middle ear infection, and this is the one that is so common in little kids. And you may have had it if you ever had tubes in your ears It was because you had recurrent otitis media infections. These are either bacterial or viral, and what happens is you end up with this pussy fluid in your middle ear, and that tympanic membrane bulges, and the classic symptoms are it hurts, and we see little 1-year-olds and like they're trying to pull on their ear because they have kind of figured, well, maybe if they pull on the ear, then the eustachian tube will open and some of this pussy stuff goes in the back of the throat, and that relieves the pressure. But the problem is, over time, this fluid becomes less water and becomes more really thick, kind of like zit thickness. And so no amount of chugging on the ear is going to make it better. So the very first picture on the far left is a really early case of otitis media, and you can tell because you can still see the fluid level hasn't completely covered the entire tympanic membrane. Whereas on the next picture over, you can see there's a lot of redness of the surrounding tissue, and that tympanic membrane is bulging, and it just looks like a little pus pit back there. Now, at this point, let me go back to this picture. You have to realize that if these ossicles are completely covered with this thick purulent material, noise conduction is not going to be normal. So yeah, your child may be saying, but mommy, you didn't say anything. And go, yes, I did. But no, your child can't hear you. Okay. All right. So if it's not treated, and by the way, we don't treat them all with antibiotics now. The American Academy of Pediatricians is recommending for, if you don't have a chronic problem, try to do the medications that will actually decrease the swelling and inflammation so the stuff can drain normally. But oftentimes, and with one of my children, he wasn't a little kid, he was much older when he had this, you don't realize until you see your child in the morning and you have all this crusty drainage on their side of their face because the eardrum ruptured and the pus back there drained out. And so that's what this bottom picture is showing. And as you can see, it's still inflamed, but it's a lot less inflamed, and you can see the pus drawing out at the bottom. Now here on the far left, this is an eardrum that has this chronic infection. And I think you can tell by looking at, see how thick that tympanic membrane looks already by comparison. So it would not be surprising if this person ended up with some degree of hearing impairment later on due to this. All right, with that, we are done with these structures and diseases related to the ear, and we will come back later to talk about hearing and equilibrium. See you soon.